I know that we will have a lot of questions and a great discussion. Just before starting this session, please be careful to switch off your mobile phone, and if you want to take pictures, use your cameras without the flashlights and sound, please. Thank you. So now I give the microphone to my co-chair, Dr. Eshre.
Yes. Well, it's lovely to see so many people here. We're going to put up first a slide to allow you to vote in favor of transferring abnormally fertilized oocytes or not in favor. And then we will take the vote again after the debate session to see if we've swung any people in favor or not in favor. So please use the QR code and make your vote. And do we see the vote come up? Next slide. So we can see 62% are in favor of transferring abnormally fertilized oocytes. So we'll see what happens. It's moving. But to start the session now, I'd like to introduce Dr. Christina Magli, a well-known embryologist in our field, who is also been the past chair of Eshre. She works in many of the special interest groups and has worked, I'm sure everyone is very familiar with her work. So Christina is going to be in favor of transferring 1PN, 0PN and 3PN. Please.
Yes, good morning, but I won the debate already.
Yes.
According to the results, so I don't have to convince anyone. So maybe, Yanis, you can come and try to convince the audience, because, I mean, I am already here. So I have to defend this yes part, and I have to say at the beginning I was a little bit hesitant to have to defend this position for the simple reasons that since when we started working in embryology lab, in clinical embryology lab, we were taught that the fertilization check was a crucial moment because it was a sort of test for ploidy. We could only live in culture those zygotes that you see the pattern there with the configuration of the two polar bodies and the two pronuclei. And not only that, but I was also hesitant because Eshre published documents, guidelines, and other documents stated that actually the normal fertilization rate is the presence of two pronuclei and two polar bodies. And not only that, but in the guidelines of IVF laboratories, for instance, they are under revision, so maybe things can change a little bit, but it is clearly written that embryos with 3 or more PNs should never be considered for transfer or cryopreservation. And similar position is for the use of embryos derived from 1PN oocyte or oocytes signing no sign of fertilization. So this is the reason why I thought, how can I defend this position? This is the gold standard. This is what we have been doing for ages. How can I defend the opposite position? Well, not difficult to think about it. First of all, I have to say that, technology progresses very fast. We have new instruments in our hands nowadays to observe our culture systems. And beside that, I have to say that irrespective of what many can think about embryologists, we have our brains that keep working and keep making observations. So some of our colleagues kept in culture these abnormally resulting patterns at fertilization, so those that were considered to be discarded, and so that actually, if they are left in culture, they can make beautiful blastocysts. So what should we do with those beautiful blastocysts? Really to throw to the beam? Let's make some consideration. Let's start with the European zygote, the so-called European zygote. There are several reports in the literature claiming that there are babies born from this type of configuration. However, if you read carefully the study, you see that they are all result of a static observation. But as you know better than me, nowadays we have time-lapse machines that give us the possibility of seeing the whole development of the oocyte after insemination. And it has become evident how these so-called European zygotes really are 2PN zygotes that simply underwent pronuclear breakdown at earlier time compared to the classical fertilization check. And in this respect, there is a nice abstract published in this, you can find it in this congress by Giovanni Coticchio, in which he really estimates which is the incidence of the true European, so European that never showed pronuclei during their development, and he saw that a very small part of this European oocyte can try to make some cleavage, but they arrest very, very early, and they never make blastocysts because actually they have a very poor development. So these European zygotes that you see quoted in bracket really are 2PN zygotes. The thing is that we never saw the 2PN under static observation. And this is logical then that if we submit to chromosomal analysis the resulting blastocysts from this European, the great majority of them are diploid. And take a look at the numbers that are reported in this very recent meta-analysis that was just published. They evaluate from the literature the live birth rate that is resulting from the 2PN oocyte, so the normal fertilization partner, and they say that is significantly higher compared to what results from the European zygote. So statistics is a matter, okay? We take the consideration, but look at the figure reported in red. It's 37% live birth rate resulting from the transfer of blastocysts from the so-called European zygote. Do you think it's negligible? Absolutely not. I think it's a very nice chance of live birth that you can offer to the patient. So, and this goes perfectly with the following studies, in which other studies in which these blastocysts were biopsied and trophectoderm biopsied and were submitted to ploidy testing. And in some cases, there were transfer with the submission with the PGTA results. In other cases, no PGTA was done at all. And as you can see, the live birth rate was really at the same level. So babies born, and this is clearly the most important point, there are not major differences regarding the neonatal outcomes. The only observation reported from this work is that babies from the so-called European blastocysts really seem to have a significantly higher birth rate, but I invite you to take note of the numbers of children that were evaluated under the 51. So it's a very small number. So we have to keep track of this observation and see if they are confirmed from bigger numbers. So this is my first conclusion. The transfer of blastocysts derived from European zygotes can definitely be considered. If we only have static observation possibilities, maybe let's concentrate on the presence of the second polar body. This is a sign of fertilization. So even if we do not see the 2PN, maybe this is a good indication. And if we are so lucky and have time-lapse microscopy, then we will see that the 2 PNs disappear much earlier. And as we know from some publication, even recent, these embryos probably have a higher chance of implantation. They are probably more competent. So yes, let's transfer the European blastocysts. Blastocysts derived from 0 PN oocyte. Let's move now to the 1 PN oocyte. It's a little bit more complicated for the simple reason that 1 PN oocyte represents a category extremely heterogeneous. You can have one polar body, 2 polar bodies. You can have pronuclei, the single pronucleus of different size in the different configuration. They can derive from ICSI, from IVF, not even mention the age of the patient. So great variability, but there is certainly one observation that this pattern struggles to develop to blastocyst. I mean, they are not dividing so well. Nevertheless, we can have blastocysts developed from these configurations, especially from 1 PN oocyte that have a big size pronucleus. So if you look at the representation of the blastocyst development in this kind of oocyte that have the big pronucleus, that is a pink bar, this is almost similar to the blue bar that is the representation of the blastocysts derived from 2 PN oocyte. Accordingly, as I said, it's a very heterogeneous group, so I can expect that the chromosome analysis is not as positive as in the previous case. Actually, here there is around 70% of the resulting blastocysts that are actually diploid. And if we go again to the meta-analysis that I described before for the 0 PN blastocyst, you see again there is a difference in favor of the blastocysts derived from 2 PN oocyte, but this is the figure, the red one, from the 1 PN oocyte, 29%. Is it so negligible? Also in this case has to be discarded as for being not considered for clinical use. Here, of course, maybe considering this 70% diploidy possibility, then we can resort to PGTA, that type of PGTA that can do biparental analysis, so we can be sure that is not the presence of the chromosomes from both parents are in the resulting blastocyst. And actually, if you look here, in the cases where this PGTA analysis was done, both the pregnancy and the live birth rate were slightly higher, but significantly higher compared to the cases where this was not done. So this is an extra tool that we can have in this case. And again, for the neonatal outcomes, there are no major differences, but it has been reported in this analysis a significantly higher abortion rate, especially at later stages. This is not good. Of course, this is not good, but again, look at the number of cases that have been considered, 75. So definitely to be verified. And this brings to my second conclusion: transfer of blastocysts derived from 1 PN zygote can certainly be considered, especially if we take into consideration some factors. Let's give preference to the 1 PN zygotes with a large pronucleus. If available, let's go to PGTA technology appropriate for biparental diploidy assessment. And finally, I told you there are differences between ICSI and IVF, and these differences are reported in this analysis. So this is an additional tool for the embryology to decide, the embryologist to decide which approach to adopt. Let's move now to the difficult part. Now it was easy, in my opinion. Now it's a little bit more difficult for the simple reason the data are not that many. This is the so-called 2.1 PN configuration. You see one very small PN is here. This configuration struggled to develop good blastocysts. Nevertheless, the few data that have been analyzed reported in the great majority, they were deployed. So the transfer, the clinical use is very modest. Only very few cases have been reported. Nevertheless, apparently, some live births have resulted. And for the 3 PN zygotes is even worse. You know, the doubt here is to have a triploid set of chromosome. This configuration can easily develop to blastocyst. If we make a diploid analysis, a ploidy analysis, we see that less than half of them are diploid. Of course, it would be important to go to PGTA analysis before the clinical use. The data, I don't think, are very meaningful because here it's about only 9 cases. So what can we say about that? There are case reports saying that there is a birth of life of a baby here, apparently healthy. There is also a report from 4 paired zygotes, but these are case reports. So this is my third and final conclusion. The transfer of blastocysts derived from 3 PN zygotes can only be considered if PGTA technology is available to assess the biparental diploidy. So let's conclude. I mean, just to put a final answer to the question, I now even more confident in saying, okay, it has been brought to the following poll that I don't think it's a moment, but nevertheless. No. Let's see and say if I can go, okay, no, doesn't matter. I just wanted to say my final slide was that now, yes, definitely, yes, for 0 PN and 1 PN, for 2.1 PN, good to go to PGTA analysis, and for 3 PN is certainly mandatory to do so, and I now feel very confident in saying this because the Istanbul Consensus document that has just been published practically states the same thing. So I already convinced you from the beginning. You had already that idea from the beginning. Now I'm pretty sure that for you is a very big deal to try to turn in the table on. So I thank you for your attention. Thank you,
Cristina. And
and we're going to take a rebuttal after Yannis comes forward and the questions, so just so you know. So I'd like to now...
have a discussion after,
I'd just like to introduce Yannis Savori. He's also a well-known embryologist here to debate the opposite from Cristina, and he's laboratory director of IVF embryogenesis in Greece, and he's the past coordinator of the SIG embryology. So welcome, Yannis. You've got a tough job ahead of you. Good luck.
Thank you very much. Let me start by saying that I think it's a little bit concerning that 60% of you are willing to transfer these blastocysts, without a second thought. So I think that for me, being the outsider is a little bit advantageous because I have the possibility to change your minds, and feel free to change your minds after you listen to my talk in the next poll at the end of this session. So let's start. So we all know that it is of paramount importance to have healthy gametes, haploid gametes that have undergone a very optimal and adequate maturation phase in order to end up with spermatozoa and oocytes that are mature, that have a single set of chromosomes that are haploid, and then in the resulting zygote, ideally what we want to have is a new diploid zygote with 2 visible PNs. However, it's very frequent that we do not always get this picture. We have 0 PNs, 1 PNs, and 3 PNs. So this is the basics of the genetics behind the haploidy, triploidy, and diploidy. So ideally, we need heteroparental diploidy. So we want one set of chromosomes from each gamete in order to end up with a normal diploid zygote. So normally, we would assume that we have a heteropaternal diploid zygote by seeing these 2 PNs. In the 1 PN case, this is usually due to errors in meiosis, so we either have only the chromosome set from the sperm or from the egg. For the triploidy, then it gets a little bit more complex, depending on where the second set of chromosomes originates. We might have digenic triploids with an extra maternal chromosome set, or diandric diploid if we had a diploid sperm, or we might have triploidy due to polyspermy. So in IVF cases, we might have the fertilization of 1 haploid oocyte by 2 haploid sperm. And in some cases, although very rare, we might have uniparental diploidy, which means that we have 2 chromosome sets only from 1 parent, so either uniparental diploid from the mother or the father. In that case, we will see 2 PNs. So let's start from the basics, and we should remember that for a long time now, you can see this paper already back from the 1980s, we need both female and male genomes to produce a diploid genome for the new embryo. We know that from basic experiments in mice that biparental gynogenomes or biparental androgenomes do not develop. So biparental diploidy is required for complete embryogenesis and a viable pregnancy. So what do we do in the lab to gain information about the chromosomal status of these embryos? We use the morphological PN check. So this is a surrogate marker of haploidy status. If you like, we can call it a pseudo-genetic test in which we use the morphology, a morphological evaluation to judge the true haploidy status of an embryo. So in the previous Istanbul consensus, it was suggested to do the fertilization check at between 16 and 18 hours. Now, in the latest Istanbul consensus, based on time-lapse observations, we know that there should be a more narrow window shifted earlier, towards an earlier observation between 16 and 17 hours. So it is true, and we saw from Christina's presentation, that the PN number may be inaccurate in predicting true embryoploidy. However, let's start with what we want to see, the 2 PNs. The 2 PN zygotes, which are with abnormal ploidy, are rare. So it has been shown that 99% of 2 PN zygotes are indeed diploid. So virtually all of them, with 0.8% being triploid and 0.2% being haploid. However, what happens with the so-called atypically pronucleated zygotes? This is a new term for abnormally fertilized oocytes. So let's start with the 0 PNs. Typically, a 0 PN oocyte indicates an unfertilized oocyte, absence of fertilization. However, in a lot of cases, if you culture these oocytes with 0 PNs, they might develop, they might start to cleave, and they might even form a blastocyst. So in that case, that means that it was a case of missed pronuclei, because according to time-lapse data, we know that there is a very good chance, if you use static observation, you may miss the pronuclei if you do your fertilization check too late. So there is this hypothesis that if you have 0 PNs outside the time-lapse incubator, you just culture them on and see if they become a blastocyst, and then you can transfer them, yeah? However, the true ploidy status of this blastocyst is not known. It has been shown that using genome-wide haplotyping, 75% of 0 PNs were shown to be diploid biparental, which is what we want. Then, after a Capalbo's review was published in 2024. They proposed that the diploidy rate is much higher, so 95% of these 0-PN blastocysts are diploid. But in another, even more recent study by Laura Girardi, this diploid status was shown to be high, a little bit lower than Capalbo's, so 87.3%. However, you must note that 4% of these 0-PNs are triploid and 8.7% of these 0-PNs are haploid. So what happens with the pregnancy rates? We have significantly lower clinical pregnancy rates in the 0-PNs, and we can see here that this statistical significance in favor of the 2-PNs as opposed to the 0-PNs is mostly in the IVF cases. For the ICSI cases, there's not a significant difference in the clinical pregnancy of 0-PNs versus 2-PNs, okay? But the overall effect seems to be significantly lower clinical pregnancy for 0-PNs. Miscarriage rates seem to be similar between these two configurations. And also regarding the neonatal outcomes, 0-PNs are associated with higher birth weights, Z-scores, and very large for gestational age newborn. So there are statistically significantly higher pathologies in the babies born. And also they are associated with lower blastocyst formation and lower good quality blastocyst formation compared to 2-PNs. Now let's talk about 1-PNs. These 1-PNs, they have been shown to be associated with slower cleavage timings, a slower morphokinetic profile in general, and lower blastocyst formation compared to 2-PNs. And they also show a higher rate of trichotomous cleavage. It has been shown, though, as Christina very nicely showed us, that depending on the diameter or the surface of the PN, of the 1-PN, we may be able to get some more information about the triploidy of this embryo. So for zygotes displaying a large PN, which is of a diameter over 30 micrometers, these large 1-PN zygotes have similar developmental potential as 2-PNs. But smaller 1-PNs, they show significant differences. And this is a meta-analysis about to discard or not to discard 1-PNs. Again, we saw that lower blastulation in 1-PNs. We have similar euploidy in 1-PN oocytes, but this is not the only information that we need in this case. We do not only need euploid embryos, we need euploid diploid embryos. And in the majority of studies, this information about the true diploidy status is not provided. Lower live birth rates in 1-PNs compared to 2-PNs in untested embryos. There's no difference in tested embryos using PGTA, and also similar miscarriage in untested embryos, and surprisingly, higher miscarriage rate in PGT-tested embryos in 1-PNs. And the neonatal outcomes are similar: malformation rates, birth weights, gestational age. So to conclude about the 1-PNs, they seem to have a reduced blastulation rate, reduced live birth rate. Miscarriages seem to be similar. So we need to be more cautious, and we need more data on more cases and more babies. 3-PNs. It has been shown that 95% of 3-PN zygotes are the supernumerary, the extra PN comes from the mother. It is good practice to check for a second polar body in these cases, but still, 92% of the 3-PNs do extrude a second polar body. They have also delayed appearance of the parental PN, and similar to the 1-PNs, they have different timings and lower blastocyst formation rates compared to 2-PNs. And the cases of transferring 3 or more PNs is very limited. We have a couple of case reports when normal babies were born. But What does the data show? Cabalbo showed that these 3 or more PNs, 53.5 of them are polyploid, so about half. However, they have included in this percentage the 2.1 PNs. So in the other study by Girardi, when examining only 3 PNs, they found that 71.4% of 3 PNs are triploid. So the vast majority of 3 PNs are indeed triploid. And the 2.1s, there is not a lot of data about the 2.1 zygotes. These are the zygotes with 2 normal-sized PNs and 1 smaller one. The question is, how small should this third pronucleus be in order to be judged as micro? Okay? So it's not easy, and especially if you do not have time-lapse, this is not going to be an impossible task. Using time-lapse, and if you spend a lot of time on your third check, you might be able to measure the size of this micro-PN, and in this study they showed that about 10 microns is the size of the micro-PN in comparison to about 25 microns diameter of the normal PNs. Not a lot of data. We can see here the triploidy rates of 2.1s. The largest number of oocytes, 23 out of 280 3PNs were triploid, so about 35% of these 2.1s are indeed triploid, and there are other studies showing with much fewer oocytes, either 0%, 4%, or 14.3% triploid. So we have to be aware to avoid triploid oocytes. And 2.1s are more or less similar to 2PNs, with the only difference that they have also lower blastocyst formation rate and lower good quality blastocyst formation. But there are risks associated. It's very simplistic to say, okay, I'm just going to culture it to the blastocyst stage, and if it makes it to the blastocyst, I'm just going to transfer it. It's not as easy as that, because especially triploid blastocysts can implant. And triploidy, we know that triploidy accounts for about 10% of all spontaneous abortions. And we know that the majority of cases are diandric triploidy due to polyspermy. And on the other hand, maternally derived digenic triploidy is due to errors in meiosis II of the oocyte. So triploid pregnancies are associated with a partial hydatiform moles and an increased risk of postmolar gestational trophoblastic neoplasia. So it's not as easy as that. The Istanbul Consensus that was just published recommends about the 2PNs that, first of all, we should not use the term 0PN. 0PN embryos do not exist. It's better to refer to them as zygotes in which PN was not observed. 3PNs, clinical use of 3PNs is not recommended by the Istanbul Consensus, and there should be cautious clinical use of 0PNs, 1PNs, and 2.1 PNs, combining blastocyst culture, so in all these cases you must culture to the blastocyst, and, if available, PGTA technology appropriate for biparental diploidy assessment. But is genetic testing for biparental diploidy always feasible? It's not. For example, in some countries, there are severe limitations with the legislation about which indications are allowed to progress to PGTA. And in some cases, for example, in Greece, you have to apply for a special permission to the national authority. More importantly, the normal NGS technology that we use, that includes whole genome amplification and chromosome copy number ratios, is not suitable to detect ploidy status. So even if you have a euploid blastocyst from a 3PN or a 1PN, you do not know if this euploid blastocyst is diploid, triploid, or haploid. So you must use more advanced methodologies using a combination of copy number and SNPs for the genotyping analysis. And again, this is a more advanced procedure. It is sometimes more difficult to access, so not all genetics labs offer this test. And there is an additional cost for the patient in order to undergo this testing. So to conclude, should we transfer these 1 PNs, 3 PNs, and 0 PNs? Collectively, if we exclude the 0 PNs, assuming that you have time-lapse in order to know if it is a true 0 PN or not, we are talking about 6% of zygotes, which is going to give you at the most 3% blastocyst. So in the majority of cases, normally we should not bother. In some difficult cases where no other embryos are available, it might be worth our attention. However, we know that these embryos have lower developmental competence and lower pregnancy rates. We should be aware of the complications of triploid pregnancies if we inadvertently transfer a triploid embryo. It requires definitely advanced genetic testing for biparental diploidy. Time-lapse in this case is crucial. So time-lapse can make all the difference in order to be able to see the true PN status of these embryos. So the absence of time-lapse is a critical limiting factor in identifying true zygotes with abnormal fertilization. And of course, patient counseling is very important before clinical use. So to answer the question, I would recommend that we should think twice before clinical use of these abnormally fertilized oocytes, and think thrice if you do not have time-lapse technology in your lab. Thank you very much for your attention.
Thank you, Ioannis, for this great battle. Very engaged, but it's not finished now. The last round.
Not at all, not finished at all. Because you mentioned a lot of very valuable points. I totally agree. This is a very minority of cases that are dealing with for this debate. It is true, very minority, but you have a beautiful blastocyst, good quality blastocyst, then you can decide what to do, depending also on the national legislations. I mean, you can decide what to do, to throw it, to analyze or not. But let's go to the matter of the available tests. Well, first of all, you make your considerations about the way this blastocyst developed. As I said, if you are so lucky of having a time lapse, but I'm not sure that everyone is, but nevertheless, you keep your mind thinking and try to find out which are the crucial factors, and we listed some that are in favor of a normal live birth resulting even from this abnormal fertilized oocyte. This is the first point. The second point, I disagree with you. I mean, I think that the majority of genetic labs now offer this so-called plus version of PGTA, that is an additional technology in which you not only have the status of the chromosomes in terms of euploidy, aneuploidy, but also the origin biparental or uniparental. So I don't think this is really true. I mean, it's available everywhere. And finally, talking about the costs. If you have this beautiful blastocyst, everyone goes for normality. Of course, we do prefer normality in all aspects of our life, or the majority of aspects. But if we have this beautiful blastocyst, and maybe you transferred already one normal to the patient, and you still have it, and what would you like to recommend to the patient? Okay, we have it, but let's don't consider because it was 1 PN zygote. You better go to another stimulation, so drugs, injections, time requested for the simulation, a surgical procedure, minor type, but still a surgical procedure, and the costs related to that, because in some countries this is fully paid by the status, what the state in other cases is not. While the cost of an additional test is maybe €100 in addition, at least in my country this is a way, compared to the conventional PGTA. So the matter of the costs, I don't think, is a point in this case. My point is, let's use all our knowledge, all our considerations, and let's go for personalized medicine and even personalized embryo. I mean, let's see which patient we are in front of, which embryo we have in our hands, how they developed, and then let's take a consideration. Now, of course, I totally agree that for 3PN oocytes, we still need, but it's written in the consensus document that we need more data. So to have more data, in some way, we have to deep the analysis and maybe to go for a transfer of this, of course, after talking to the patient. So this is my point. These are my points.
Ioannis?
I thought it was going to be a kiss and makeup rebuttal. So you do have indeed very strong arguments, Christina, and I do agree with most of them. I have to admit, we should offer personalized medicine and judge each case on its own merits. However, if it was easy to put up another poll, how many of you would transfer a 1PN embryo that makes it to the blastocyst without any further genetic testing? Yeah, I think all of us, including myself. Okay, so we have to be cautious. We have to think about what it is that we're doing, and we have to explain to the patient and to the clinician as well what an abnormally fertilized embryo is. Regarding the technology, I think that time-lapse can make a significant difference in discriminating the true 0PNs, the true 1PNs, because in 1PN might be a 2PN with an asynchronous PN fading, okay? To judge a true 3PN or a 2.1, especially if we have the ability to measure the exact surface of the PN. So my hesitation would be even higher for laboratories without time-lapse technology. So with just a static microscopic observation, we know that there is a lot of information that can easily be missed, and we can inadvertently transfer beautiful blastocysts, as you say, that are chromosomally abnormal, that are either haploid or triploid. And you will say, okay, if I transfer a haploid embryo, the chances are there will be no implantation. But for a triploid embryo, it has good chances of implanting and of creating problems. So, because I also work in a real-world laboratory and we are faced with these questions every day, I do agree that these abnormally fertilized zygotes can indeed increase the number of usable blastocysts, and especially for difficult cases, patients with very few embryos, patients in which the only embryo is a 1PN or a 3PN. So my recommendation would be to be cautious, to consider all available options, to inform the patient, and to definitely have this advanced genetic testing for biparental diploidy. So I think that more or less we agree.
I don't know.
Yes?
I agreed with myself from the beginning. You were the one that were in the no position. So
I'm still in the no.
But I am in the yes position.
I'm still in the no, and I think now it will be 50-50 in the poll.
No.
Should we maybe bring up the poll
Yes,
and see,
let's
before
do
we
it.
take questions from the audience, if we could please ask the technical support to bring up slide number 25 and 26. And then we will let the floor, if you have questions or opinions in the floor, it would be interesting to hear how you're working in your own laboratories. So please approach the microscope.
There.
I have a question.
Yes.
I have a question for Dr. Magli. Hello.
Yes. Yep. Yeah, we were waiting for the voting, but I don't know if it is. coming or, okay, no problem. Please go.
I can't see.
Jerome Pfeiffer from
Which
France.
side? Wait.
Hand up, please, and introduce yourself. Yes, perfect.
Okay.
Jerome Pfeiffer from France. 1 p.m. is the big matters because with time lapse 0 p.m. because it disappears and 3 p.m. And 1 p.m. So I have a question about 1 p.m. and without time lapse involved, let's say that we check the 1 p.m. Even on static observation, it's a real 1 p.m. You didn't talk too much about the way that IVF or ICSI can be involved in the selection of the blastocyst. And my question is, can you remember why IVF blastocysts are more safer than ICSI blastocysts to the audience? And the PN from IVF, is it related more bigger than the PN from the ICSI?
Well, for the first point, I really have no idea why IVF and ICSI are behaving differently compared to the development of this 1PN oocyte. There is one nice work in which it was seen that if the entry of the oocyte is very close to the first polar, the entry of the sperm into the oocyte is very close to the first polar body, then there is a higher tendency to develop 1PN oocyte. So there must be something occurring at this point when the sperm enters and is very close to the meiotic spindle, and maybe during the condensation, the chromosomes are engulfed in those of the oocyte. So, there are possible mechanisms. What we are seeing, analyzing the data from the literature, that in ICSI, the cases of 1PN oocyte that develop to blastocyst have exactly the same live birth rate compared to the 2PN oocytes. I can speculate that maybe in ICSI we explicitly inject the sperm far from the first polar body. So I don't know if this can be the reason. I don't know if you have any other...
Yeah, I agree. And this hypothesis, I think it has a very good basis that a 1PN that might be diploid might arise in these cases where the sperm has entered at the point of the female meiotic spindle. So you might have both chromosome sets in one visible PN. And also in the meta-analysis that I showed, we saw exactly that in the sensitivity analysis, pregnancies from IVF were statistically significantly lower in 1PNs compared to 2PNs, but in ICSI pregnancies, there was no difference. So we do assume that first we know that with ICSI cases, we have injected sperm, so there is a spermatozoa inside the oocyte. And second, we do avoid injecting the oocyte next to where the maternal spindle is hypothetically located.
Thank you. Here, yeah, please.
Hello, Luminary Genetic in United States. If the advanced genetic testing platform used such as single nucleotide polymorphism testing methodology, would you completely recommend to stop not doing the fertilization check any longer?
Would you like to take it?
Well, no, because I would apply PGTA, that type of PGTA, the PGTA plus or whatever you want to call it, only to specific cases, unless you tell me that you want to apply PGTA to everyone. Maybe in the future it will happen because patients want more and more and more to be safer and safer. So I don't know, but yeah, I would keep doing fertilization check anyway.
Thank you. Yeah, I have
So
question.
you said no this time, Christina, and I do agree. Remember that the 2 PNs are 99% diploid. So I do not think that we should go to extremes and apply molecular fertilization checks to all the oocytes. We should keep it for these few cases that are worth our extra attention.
Please.
Thank you very much for a nice presentation. If we don't use time-lapse, and in your practice, from what case is the better result after PGTA in 2 and 1 pronucleus with 2 polar bodies, and after IVF or after ICSI, about results of PGTA? They are the better results.
I do not have any PGTA results about that.
I never read anything
Yeah,
regarding PGTA. What we saw, what was Yanis was already mentioning, that the live birth rate in the different reports are exactly the same in 1 PN oocyte. But as I said, it's such an heterogeneous group, and it's very difficult to draw conclusions. So this is why we definitely need more data.
And also for the 2.1 PNs, remember that it's not a frequent event, it's rare. So it's about 0.5 to 1% in various studies. And we have few cases. And also, as I said in my presentation, how do you decide how small is small? For example, in our lab, there are many occasions where we have to ask for a second and third opinion in order to decide if what we are seeing is a 3 PN or a 2.1 PN, because the smaller PN is not very small, it's not very big, it's somewhere in the middle, so it's not easy to say that definitely it's a 2.1. So this is a gray area, and I think we need more studies about the exact diameter of this micro PN.
Okay, so we have just a few minutes, so short questions and short answers, please.
Sorry, the mic. Yeah, thank you so much for Eshre to bring this topic. So we perform at London Women's Clinic, by the way, Balsam Al-Hashimi from UK. Very large, it's not very large, but it's a study whereby we included around 150 embryos, whereby we tested them biparental. And we were able to classify those embryos that resulted from IVF versus ICSI. And all the embryos were cultured in time-lapse incubator, and we found 0 PN nearly not exist. For 1 PN IVF, we reported around 94% were diploid, with a significant number of euploid. With 1 PN ICSI, we found 52% were diploid. 2.1 or micro PN, if you have good embryologists that they can determine micro PN, they were reported 100% diploid. For 3 PN, we found in IVF around, in ICSI, 25% were diploid. And if I can find my figures, and in 3 PN and IVF were 43 diploid. So again, for IVF, you can transfer if you found that, because majority of them are diploid, and if you have defined or fragmented polar bodies. For checking or not to check PNs, I think we should check, and we should definitely give chance for those embryos, because we have reported live birth and ongoing pregnancy in our studies.
Thank you. This wasn't a short question. Please.
Hi. Yes.
Miss.
Hi, I'm Mireia Sandalinas from Dina Science. Thank you very much for your great presentation. We've been applying your recommendations. We have the technology of study biparental as the only, and it's what we strongly recommend in order to transfer blastocysts derived from these abnormal ones. But looking at your numbers, what I'm wondering is if we should check for biparental diploidy in all of them, or just in 1 PN, 3 PN, because the numbers that you presented with 0 PN, I mean, what do you recommend to go ahead with the PGT with parental samples, even though the results?
Mireia, I think that an answer could be given by you because you're the one making this type of analysis. We just read what is in the literature. Actually, we didn't find anything. So
we have the technology for many years right now. Our
publish the data.
No, I know, but we have few numbers with triploids and non-diploid at the moment, but with 0PN. Now, till now, centers were very reluctant to just spend money on this. So I'm just wondering, because we think that we have to check, this is too early, we have to check biparental for every abnormal zygote. So just wanted your confirmation.
I would do for 1PN, 0PN, I don't think it's needed.
Necessary. Okay.
No,
it is recommended in the Istanbul Consensus.
Okay.
To use biparental analysis.
Yes. Thank you for this great session. We saw some videos that they can aspirate 3PN on day one. Especially the 1PN is far from the polar body. So the question is, can we use such micromanipulation to aspirate the extra copy of PNs currently? It can result normal embryos?
Well, it has been proposed time ago, I think, and you can do it, but then the analysis, the PGTA plus analysis, of course, you cannot do without it, just to be sure that you have removed the correct extra pronucleus.
Yeah, exactly.
Yeah, any instructions to predict the extra copy or the extra PN?
Well, you have to be able to identify if you have two maternal or two paternal PNs, first of all. Yeah. So, and then you have to be able to remove the extra PN. Okay. Clinically, definitely not.
Yeah.
At this point, and even if you do that, I don't know if it's going to be within a research license. Definitely, it has to be confirmed by parental ploidy analysis.
Okay, thank you. Thanks, Miss.
Thank you very much for your argumented presentation. I ask if some conditions, culture conditions, laboratory conditions could have an impact in an abnormal formation of zygotes, of PN. For example, if, especially with vitrified and thawed oocytes, if we wait 2 food times, such like just 1 hour after thawing oocytes and perform ICSI, could we have more abnormal zygotes because the tubulin has not time to polymerize, for example?
Not in my experience. We do a lot of oocyte thawing, but not in my experience, so I don't know.
I'm not aware of any effect of oocyte freezing. There are some assumptions about the potential effect of osmolarity, for example, in 3PNs, but I don't think that there is data out there to support it, definitely.
Last question there.
Thank you. Nejati Findikli from Belgium. My question is related with the clinical strategy. So I think everybody agrees that the embryos could be transferred with certain genetic testing. But, how can we manage it clinically? Because if we culture the embryos to blastose stage with 1 or 2, let's say, potential embryos, these patients need to have genetic counseling first. So you need to freeze the embryos, right? And the biopsy, without biopsy, that's the first question. Is then if you have such clinical strategy, so what happens if you have such embryo as a 7th embryo? Would you also offer genetic testing as a 7th embryo?
Well, these are the difficulties that I mentioned regarding the feasibility of doing genetic testing in all these cases. So if you counsel the patient and you have to freeze the embryo before biopsy, or you have to freeze the embryo and then thaw it again and biopsy and refreeze, then all these are logistics that have to be taken into consideration depending on the patient and on the case. Now, if I had 6 blastocysts and there was an additional one which was abnormally fertilized, then again, you have to discuss with the patient what it is that they want, what extra interventions they need, what extra cost they need to cover in order to make a decision. I don't think there's a black and white situation in these cases.
So you individually manage the cases in your clinic?
So in our clinic, we do exactly that. So you have to, we might, very usually, we might freeze the blastocyst, okay, and then discuss options and possibilities, and then we might even, thaw the blastocyst and biopsy and refreeze. That gives you more flexibility compared to having to make the decision on the spot, because you say I have a blastocyst now and I either transfer it or freeze it, decide this moment. So it's not always easy to make these choices.
Okay, I'd like to close this session and thank the speakers very much for an interesting debate. We see the result here. It was pretty much 64. Christina, you did a great job. You held your ground.
Congratulations.
And thank you everyone for joining us.
Thank you. Thank you very much.